I've been involved with quite a lot of different research. So my primary area of research, yes, is musculoskeletal orientated, but been involved with lots of other conditions, worked with lots of different professionals as well. But this is my prime area of interest, prime area of expertise, which is around joint hypermobility. And the quotation that's there in the title we'll come back to later on, and we'll revisit it at the end as well. Just a little bit more about myself. This is where I do my bit for the Northern Ireland Tourist Board as well. So I'm originally from Enniskillen, so a beautiful town in the most beautiful county in Ireland. I'm not biased, it really is, and there's the photographs to prove it. And I suppose growing up, I was very sporty. You might not know it by looking at me now, but I was a swimmer when I was growing up, loved cycling, loved being outdoors. My dad was a big fisherman, so we used to fish quite a lot on the lakelands around Fermanagh, so lots of happy memories sort of growing up. But very early on, I developed an interest in the human body and human performance and nutrition and all of those things. And very early on, I decided I wanted to become a physiotherapist, and that never left me. And I'm very lucky, really, that I've ended up doing exactly what I always wanted growing up. So that's just a little bit, I suppose, about where I'm from. The professional journey, Rosie's already said most of this, but what you will pick up is that I have now lived and worked in all of the 4 home nations. So it gets very confusing at this time of year with the Six Nations Rugby Championship as to which match I should be watching, and invariably I end up watching them all, which is interesting at the weekends. I suppose now, I suppose the other thing just to say about this is that you'll see that I'm sort of averaging about a 15-year or so relationship with each institution. So Queen Margaret in Edinburgh, University of the West of England. So I'm hoping that this relationship with UHCW and Coventry University will see me through to retirement. Okay, so that's the wish. But why I've particularly ended up here in Coventry is the Centre for Care Excellence, okay? So I think this is a really exciting partnership between Coventry University and University Hospitals Coventry and Warwickshire NHS Trust. I think there's a real opportunity for us here to really push forward clinical academic careers in allied health professions, nursing and midwifery. So when I saw the post advertised, got chatting to Rosie, we had a couple of chats before I was interviewed for the post, but it was a complete no-brainer. I think this is a model that on paper sounds as if it should work. It's up to us. It's great to have other professorial colleagues that have been appointed as part of this initiative here tonight as well. It's just going to be really exciting to see what we can achieve. Okay, so really, really excited to be here. So this is an overview of what we'll try and cover tonight. So I'll give you a little bit of an introduction to what we're talking about when we talk about syndromic joint hypermobility. So the technical terms are hypermobile Ehlers-Danlos syndrome and hypermobility spectrum disorders. So that's what those acronyms stand for. I'll particularly focus on our research, so the research that I've been involved with lots of different colleagues, particularly PhD students as well. And then again, we'll just try and pull everything together at the end. So, what are we talking about then when we're talking about syndromic joint hypermobility? I think the first thing to note is that often when people think about people being double jointed or having joint hypermobility, this is often what is conjured up, okay? As well as the circus tricks that people at school were able to do, this is also what is conjured up, okay? So people in sport, in the performing arts, who are performing at quite a high level, partly because of the position that they can get their joints into, okay? So people like swimmers, weirdly, weightlifters as well, being able to get underneath that bar and get it up, gymnasts, obviously, and then lots of musicians and ice skaters and ballerinas, etc. Again, this is what we think of often when we're thinking about hypermobility. This is when hypermobility is an asset, okay? It is allowing people to perform at quite high level, okay? but this is not what we'll be talking about tonight, okay? But this is normal. It's quite prevalent, actually. So some of the epidemiological work we did, almost 20% of 14-year-olds will score positively on what we call the Baton score of joint hypermobility. Very common, okay? Nothing to be concerned about, okay? So this is joint hypermobility as an asset. However, for some people, joint hypermobility becomes a problem. So particularly where they're unable, perhaps, to control the movement of that joint, then that can then start to become a source of pain, okay? That pain then becomes a source of functional deficit, starts to impact on all areas of their lives in terms of their quality of life as well. So this is what we'll be talking about, okay? In some cases, it can lead to things like dislocations, so shoulder dislocations, patellar dislocations in particular, in these examples, but even things like flat feet, okay, can cause real functional difficulties, functional impairments for people, okay? But so this is what we're talking about. So problematic joint hypermobility, when it stops becoming an asset, it starts to become the source of a problem for people. And this brings us to this statement, okay? So this is a quotation from a member of a focus group, so somebody with hypermobility. And this quotation always sort of conjures up a number of different things to me. I was actually there in that focus group, and I can say that it was said with an element of humor. So there was an element of humor in the way that it was delivered, but underneath it, there was this real frustration that people with joint hypermobility, and this woman in particular, have real difficulties in explaining their symptoms, explaining their problems to health professionals, and then health professionals have real difficulty in making sense of that information, processing that information, and definitely have real problems in knowing what the heck to do with it, with that information, once they are able to process it. And aligned to this is lots of examples of all of the medical students being brought into the cubicle, wait until you see how much movement there is, and the pulling and the prodding, and almost being a center of I wouldn't necessarily say the word fun, but of curiosity, I suppose, would be the word I would use. Okay, so this real curiosity around joint hypermobility sometimes. So I thought that sort of sums up for me. I think that a lot of the issues around identification of the problem, making sense of the information, patients getting their messages across, and then health professionals actually being able to do anything about it as well. Okay, and we'll come back and we'll revisit that later on. So what we're talking then about is syndromic. Okay, so I'll use this term syndromic joint hypermobility. Okay, so joint hypermobility that is causing a problem. Okay, it's a syndrome. You will see lots of terms. The diagnostic criteria were updated in 2017. So the terms hypermobile EDS and hypermobility spectrum disorder are what should now be used. But obviously, if you look back historically at the literature, you'll see things like joint hypermobility syndrome, Ehlers-Danlos syndrome, hypermobility type, Ehlers-Danlos syndrome type 3 rather. There's lots of other terminology that sort of sits behind it. And it does cause a problem, actually dealing with the literature, this sort of constant changing in the diagnostic criteria. But again, if you think about hypermobility being on a spectrum, you've got asymptomatic joint what we call generalized joint hypermobility, so people who are just naturally bendy but don't have a problem. Over on the left-hand side, normal, not an issue, but over the other side, you've got your HSDs and your hypermobile EDS, okay, with hypermobile EDS being at the more severe end of the spectrum. And these are connective tissue disorders, okay? So although we're using the term joint hypermobility, actually the joint is just an indicator of what is happening perhaps more widely within the connective tissues within the body, okay? So there is a focus on the joint as part of the diagnostic workup, and it's in the title that we're using here as well. It's also part of the main symptomatology, so the joint laxity and the pain within the joints as well. But you'll see that there's lots of other things going on there as well. So in terms of proprioception deficit, fatigue, been illustrated, strength deficits, all of these things as well. But potentially some more serious things, so things like prolapse, things like poor healing can again be a huge issue in these conditions as well. And don't forget impacts on other body systems, not just the musculoskeletal system. So again, things like gastrointestinal symptoms, cardiovascular system can be affected in these conditions as well. And I suppose the message to clinicians would be that, if you've got people coming into the clinic and you're unable to sort of diagnose a particular problem, just screen for some of these things. Or if some of these things are coming up in the medical history that you're taking, then it should be ringing some alarm bells for you to think about joint hypermobility syndrome, as was, so hypermobility spectrum disorders or hypermobile EDS, as a potential other diagnosis. So it should be something that you're thinking about. And why this is of particular interest to me as a physiotherapist is that physiotherapy is the mainstay of treatment. It's not the be-all and the end-all. We're part of a multidisciplinary team. But if you think about, if there is a problem with the elasticity of tissues, there isn't that passive stability within the joint. The only way that you can get stability within a joint is from the muscles surrounding that joint. So exercise becomes really key to management, and therefore physiotherapy becomes key to management as well. Quick note on Ehlers-Danlos syndrome. So there are actually 13 different types of Ehlers-Danlos. So what we're talking about tonight is just one of those. But 12 of the 13 different types of Ehlers-Danlos syndrome have genetic markers. Okay, so the geneticists often are involved with the diagnosis of these. Some of them are quite serious. Again, if you think of potential impacts in terms of heart defects, for example, okay, then some of them can be life-threatening. But there is a genetic basis to 12 of the 13. But the most common one, hypermobile EDS, does not have a genetic marker. It is based on a clinical diagnosis. But up to 90% of all EDS patients will be hypermobile EDS. It is known that there is an autosomal dominant inheritance pattern, and there is a large genetic study ongoing at the moment, so the HEDGE study. So this might change, okay? They may identify a gene. Much more likely, it's going to be a whole host of genes that they identify, if they're able to identify anything. Okay, so, but just to say that it's part of the overall EDS picture. And there are diagnostic criteria, as I said, 2017, these were updated. So there's sort of 3 stages to that diagnostic workup. The first one is that you've got generalized joint hypermobility. So we use, so the pictures along the bottom are what we call the Baton score. So basically you score a point for each of these things that you're able to do on the left-hand side and on the right-hand side. So if you can pull your little finger back, this is normally when people start doing it. If you can pull your finger back 90 degrees, you get a point, 1 for the left, 1 for the right. If you can pull your thumb down onto your forearm to touch your forearm, again, a point for the left, a point for the right. Hyperextension of the elbows by 10 degrees, again, point for either side. Hyperextension of the knees by 10 degrees, and then long ago lost the ability to do this one, but being able to put your hands flat onto the floor with your knees straight, again, you would score a point for that as well. So there's 9 points on offer. The new diagnostic criteria for people who have gone through puberty and before they age 50, I'm just gone the wrong side of that, it would be 5 out of 9, okay, to sort of meet the diagnostic criteria. Becomes 4 out of 9, because generally we get a bit stiffer as we get older, so once you turn 50, it's 4 out of 9. And for kids, it's 6 out of 9, okay? So that's sort of part of the workup, but then you've got all these other things as well that you need to meet. So they're a lot stricter than the previous criteria. So the old joint hypermobility spectrum, joint hypermobility syndrome diagnostic criteria. And helpfully, the EDS society, so this is the International Society, I know it's a little bit blurred, but they've got a checklist, okay, that you can actually work your way through as a clinician to, again, make that diagnostic workup. And where people have symptomatic joint hypermobility, but they're not meeting those very strict criteria for hypermobile EDS, then hypermobility spectrum disorder becomes the fallback position, again, in the absence of other diagnoses, okay? So again, it's a syndrome. There's nothing very scientific necessarily about the workup of this. But basically, if there is problematic joint hypermobility in the absence of inflammatory disease and other types of potential diagnoses, then hypermobility spectrum disorder can be used. And again, there's a couple of different subtypes, but by and large, it's the generalized hypermobility spectrum disorder that we deal with in clinic. Okay, so that's just a quick overview. In terms of prevalence, again, I've already alluded to the problems of historical variation in the diagnostic criteria. People historically have used different cutoffs on that Baton score. Some people use 3, some people use 4, some people use 5, some people use 6. So classifying people as having a syndromic hypermobility disorder is really difficult when you're looking historically at all of this literature. So this is why the variability or the prevalence estimates sort of vary so much. But you'll see that there's prevalence estimates anywhere from 0.02% of the general population up to 3.4%. And I've been very careful to put in the definitions that people have been using, because again, they're doing this in different ways. So the last study by Mulvey et al. Was a postal questionnaire, so a large epidemiological study, for example. So they're using what's known as a 5-point questionnaire to identify the joint hypermobility, and then it's self-reported pain, etc. So it's difficult, as all epidemiological research can be. Okay, but potentially in the general population up to 3.4%. What is more certain, however, is the proportions or the prevalence in clinical populations, okay? So if you look here, we're looking at between 46 and 31% of men and women, respectively, being referred to rheumatology clinics in the UK. 55% of women referred for physiotherapy in Oman, so to musculoskeletal physiotherapy. 30% musculoskeletal triage service, again in the UK, and again a range of different clinics in the UK. You can see the prevalence there as well. Now these are a little bit more certain because these are people who were prospectively screened for the diagnostic criteria. Okay? But you'll see that within musculoskeletal services, it may not be as rare as we think. Now, a lot of these patients are probably coming in with other things, and they will be diagnosed with those other things as well. However, those are quite large proportions who are also meeting the diagnostic criteria for hypermobility syndrome. Okay? And this was the old criteria. These are all JHS, so joint hypermobility syndrome. That was the term that was used in the diagnostic criteria that was used pre-2017. Okay, but we're potentially talking about something that's going to be a large proportion of what people are seeing within physiotherapy, within rheumatology, orthopedic, pain type clinics. So, what have we been doing about it then? Okay. I would like to just acknowledge these are 3 PhD students that have been working in this area. So Francis Fatoye was my very first PhD student, and I'm delighted he's got his own professorial position now at Manchester Metropolitan University. Absolutely fantastic guy, but it was him that got me interested in joint hypermobility and his work. Okay, so we'll talk about that in a moment. Najla Al-Suri is now finished and is working back in an orthopedic specialist hospital in Kuwait, but again, we're continuing to work on some diagnostic work in joint hypermobility. And Sarah Bennett, again, we're actively working with Gemma Pierce on some postdoctoral work with Sarah, so hopefully we'll get some funding. And we're absolutely delighted that we've managed to appoint her as an honorary research fellow here in Coventry as well. So we're trying to reel her in and get her sort of involved and working with the group here in Coventry. But you'll see these names popping up again and again on some of the subsequent slides. Okay, the amount of work that these guys have done is absolutely phenomenal. Okay, along with lots of other colleagues that I haven't specifically mentioned. Okay, but there are lots of other colleagues that have been involved with this work as well. And what we've tried to do is to take a very broad-based approach to trying to sort of work in this area. So we've, yes, done some epidemiological work with colleagues at the University of Bristol, and we've tried to conceptualize the impact of joint hypermobility on people using the International Classification of Functioning Disability in Health. Okay, so we've tried to use these terms of impairment, activity, and participation to really try and conceptualize the impact of these health conditions on the people themselves. A lot of our research, we try and make sure that our outcome measures that we use reflect these three different levels of human functioning as well. Okay, so it's been quite central to a lot of what we do. We'll talk in a moment, but we've developed an outcome measure to try and actually measure that impact much better. We've obviously done systematic reviews in this area. We've really tried to understand, because physiotherapy is key often to the management, we've really tried to understand physiotherapy, so both from a patient perspective and from a healthcare professional perspective. And finally, we've gone on and we've developed and evaluated a physiotherapy intervention for people in this area as well. So what we'll do is just pick up on some of these areas again in some of the subsequent slides. So the first thing then is about the impact. And as I said before, Francis Fatoye's work was really what sort of got me interested in joint hypermobility. I must admit, I'd never really heard of it, didn't understand it was an issue at all, until he undertook his research looking at children with this diagnosis. And what he did was basically to have a cohort of children who had been diagnosed with joint hypermobility syndrome and to compare them with age and gender-matched control children. And what he found was that absolutely everything that he measured, okay? So pain, strength, range of motion, proprioception. We did really complicated 3D motion analysis of how they walked, how they moved, and we looked at quality of life measures as well. Everything was severely impacted in kids with the diagnosis of joint hypermobility relative to their age and gender matched controls. And if we take quality of life, it wasn't just the overall score of quality of life, it was every subscale. How they were getting on at school, their emotional functioning, their physical functioning, everything was severely impacted in this condition. And it really, I think, was a bit of a wake-up call, both for him and for me as well, as to, why aren't these kids being picked up? How do we sort of better manage it, really? So that was quite a turning point, really. And Najla's work repeated it. It wasn't using exactly the same outcome measures, but she did do 3D gait analysis, but used some slightly different outcome measures, but found exactly the same in adults. Okay, so again, pain. We looked at tendon stiffness, muscle elasticity, etc. But again, gait, vertical jump, left off. There was quality of life, so the SF-36 was in there as well. Again, all negatively impacted. Okay. And you'll see that those outcome measures, again, have been chosen to reflect the International Classification of Functional Disability and Health. There's the really basic impairment level outcomes, like pain and strength, for example, but we're also making sure we're looking at function in terms of gait and jumping, in this case, and also quality of life as well. Okay? And another example of impact, this was part of the development of our outcome measure, and we asked some supplementary questions as well. But this was over 600 members of the Hypermobility Syndromes Association, and what we can see here is that in terms of the site of pain, if we use 80% as a cutoff, 80% of people or more have pain in the neck, hips, shoulder, knees, and low back. Okay? So we're not just talking about back pain or knee pain. We are talking about a population here who have multiple joint pain. And in fact, the median number of joints was 8 out of the 10 areas that we talked about. Okay? So, and if you look at the median pain score, it's 6 out of 10. That is moderate to severe pain in 8 areas of the body, okay? So this is a huge impact if you're just thinking about pain. In terms of fatigue, we used the Bristol Rheumatoid Arthritis fatigue scales. They're quite generic in terms of the wording. We thought they would fit the bill. And what we found was that the 3 scales, which look at the severity of fatigue, the effect that fatigue has on people's lives, and their ability or inability to deal with fatigue or manage their fatigue, was similar to rheumatoid arthritis. And people think of rheumatoid arthritis as being a really serious gig, you know, in terms of getting it, okay? But fatigue in this population of joint hypermobility syndrome, the same. And in terms of the SF36, so the short form 36 questionnaire, 88% of respondents were below the population norms for the physical component score and over half for that mental component score. So again, just an indication, I think, of the impact that these conditions are having on people. So that's the impact. In terms of understanding patients' experiences and clinicians' perspectives as well, we've got a whole host of qualitative research work. So I'll just sort of flash some of them up here. So this was a focus group study, so looking at experiences of diagnosis, referral, and self-care. We also, as part of those same focus groups, actually had a section that was specifically focused on physiotherapy interventions, and we also ran focus groups with clinicians to understand their perspectives around physiotherapy. As part of developing our outcome measure, we had open text boxes. Hadn't really thought about how we were going to analyze those. But there was a whole paper that actually came out of that because people, of course, because they hadn't been listened to, hadn't been able to get their stories across, spent lots of time filling out those open-ended questions. So we were really lucky to be able to look at that in detail as well. So there's some really rich information come out of that. And then Sarah's work. So Sarah did a lovely systematic review and thematic synthesis of the qualitative work in this area around patient experiences, lived experiences, so a really lovely paper there. And then followed that up with the largest interview study that's ever been done in this population, specifically focusing on the psychosocial aspects, because that was something that we spotted hadn't really been covered well. Okay, so there was a specific focus on psychosocial impact as part of that work. So some really nice series of papers there. But if we just concentrate on the outcomes from the focus group work, okay, just to give you sort of a flavor, we had 4 main themes. So this is the first main theme, which is around impact. And some of the candidates we've already talked about are already in there, like fatigue, pain, proprioception, etc. But the ones I've highlighted, I think, were really interesting and something that's quite different, I think, around joint hypermobility. They're both sort of interlinked, but there's something here, I think, around the slow healing that people have, okay, with these conditions, okay? Because they're slower to heal, then they're out of action, if you like, a little bit longer. when they injure themselves. But also there's this repeated cycle of injury as well. So there's slow recovery, well there's injury, slow recovery, but then potential re-injury because of the damaged tissues, because of fear, because of all sorts of other things, proprioceptive deficits, etc., that are there as well. So some of the stories, some of the narratives around that, I think were really, really interesting, really revealing. JHS, a poorly understood condition. Again, I've touched upon this already, but these stories are quite common. And part of the issue here is this one. So the one in the middle, so distinction between joint hypermobility, so what we call generalized joint hypermobility, people who are naturally bendy, and joint hypermobility syndrome. Okay, there is a lack of distinction there, both from a health professional perspective, but also from friends, family, society, etc. as well, that can't quite square joint hypermobility. So the first pictures that we looked at, so the sportsmen and the musicians and the dancers and all of these people, they can't quite square that image of joint hypermobility with somebody having a real health issue and a health problem. Okay? So again, lots of narrative about that distinction and making that distinction from patients as well. Diagnosis was a huge thing, and again I've highlighted the bit at the bottom there, which is about the fact that once the diagnosis came, very often it was life-changing for people. It actually, I think particularly when it was associated with onward referral to somebody who knew what they were doing. So when they found a good physiotherapist or found a good multidisciplinary team, that was quite transformational for them. So there was a lot of positivity around some of this, but also the frustration of how long it took to get there. Again, stories of 30 years of problems before that diagnosis was actually made. Okay, but as I said, some positives there. And in terms of management and self-care, again, lots of positives. So yes, lots of negatives there, but some really positive things that helped us then when we were thinking about developing our physiotherapy intervention. And this idea, this message really that came across about that patients were looking for long-term management. I would say this was the only area where there was a little bit of a mismatch between health professionals and patients. So health professionals said that sometimes patients were a bit unrealistic, that they were coming in, they were expecting a quick fix, and for the physiotherapist to cure their ills, okay, cure their problems. Whereas that was not evident at all in the patient data. The patient data, they were very clear they had a long-term condition that they were going to have to live with and learn to manage, okay? So, but in all of the other areas, there was actually quite a lot of overlap. Okay, the physiotherapists and other health professionals seem to really understand the patients, and what they talked about matched what the patients were saying. So an interesting area there as well. And again, around this, in terms of physiotherapy management, so we did a UK-wide survey. Again, I'll not dwell too much on this, but just to say that, I mean, these are health professionals that have a declared interest in joint hypermobility, yet less than a third of them actually have any training in joint hypermobility, and less than a third of them were actually using the diagnostic criteria that were around at the time, okay, which is really, really interesting. Again, some positives there, that what physiotherapists were saying that they aim to do or aim to achieve, and their description of what they do actually seem to match quite well, and match quite well with what we would hope to see, I think, in chronic long-term management as well. So again, there was some positives there. A little bit of a mismatch in terms of assessment. So physios were saying that, well, you know, getting rid of pain wasn't a main aim of treatment, but yet it was the first thing that they measured. Okay, was pain. So we felt there was perhaps a little bit of a mismatch there. And we got really good picture, I think, for what a typical service looks like. So again, I'll not sort of read out the details there, but there's, we just got a good flavour for what was on offer within the NHS. So our conclusions were management yes, largely seemed appropriate, but there's room for improvement, particularly around diagnosis, but also around assessment. And this was a list of what an ideal service might look like. Okay, some of them not surprising. Whatever service we went to, we would probably want to know that the health professional knew what they were doing. So that's probably not surprising. But again, some of the ones I've highlighted at the bottom there are probably a little bit more specific. So again, this idea of not just treating the left knee because the left knee happens to be the most painful at this moment in time, to see the whole picture, particularly connective tissue disorder that affects the whole body, thinking about biomechanical chains and treating the whole body was something that came across really strongly, again, from therapists with a special interest in the area and from the patients themselves as well. And in terms of assessment, and this area of research was driven very much by our local hypermobility service, who had been looking for ages for an outcome measure that would really capture the experience, again, of patients and what they were saying was their experience, and also capture the improvements that they thought that the service was making. Okay, they were really struggling to find anything. When we looked at the literature, there were two potential candidates, so the SF-36 and a more generic arthritis outcome measure, so called the AIMS-2. They had been shown to be sensitive to change to exercise interventions, so it looked as if they might fit the bill. But when you looked at the questions, again, they were very generic, weren't really sort of picking up a lot of the specific things that patients were talking about. So we made the stupid decision to develop an outcome measure, okay, so as you do. But we thought that was important. If we were really going to get involved with research in this area, we needed something that was condition-specific, okay, that was likely to be sensitive, reliable, valid, etc. So what we did was to develop the Bristol Impact of Hypermobility Questionnaire in close collaboration with clinicians and with patients. Patients generated, obviously, all of the items on that questionnaire. And we went on to validate that. Okay, again, it captures a range of impairment activity participation level outcomes, but we showed that it correlated particularly strongly with the physical component score of the SF-36. And we anticipated that would be the case because most of the items in there are around physical function. Although it's capturing other things, the majority of it is around physical function. We then went on, we did a reliability study, showed very high reliability, so an intra-class correlation coefficient of 0.923 is really strong. We worked out the smallest detectable change, so this is how much of a change on the score might be considered clinically relevant. Okay, need to be a little bit hesitant with that interpretation, but basically this is the amount of variability that you would sort of see within the data. So anything above that 42 points is going to be beyond that statistical variability, if you like. And we found that it was better than the SF-36, so we used the SF-36 alongside it, so it was more reliable than the SF-36, and also this amount of change as a proportion of the baseline scores was much smaller as well, so it's likely to be more sensitive to change than the SF-36 would be as well. And that was encouraging because we knew that the SF-36 does change from some of the other research with physiotherapy type interventions. We then did some qualitative work in this area as well, looking at different aspects that the health technology assessment program would suggest that you need to demonstrate for people when they're choosing outcome measures, so appropriateness, validity, acceptability, etc. And again, got really positive feedback from both patients and from clinicians. So we use cognitive interviewing, so where people are filling it out and talking as they're filling it out. Okay, got some really rich data from that as well. And finally, we did a known group validity study to demonstrate that it can actually distinguish between people who do have a diagnosis and those who don't have the diagnosis, which again is crucial for any outcome measure. Okay, so hopefully we've got a good a good tool there as well. And again, all of this is in the public domain. Quick note on tissue mechanics. Okay, remember these are connective tissue disorders. Very little in the diagnostic criteria about assessment of the connective tissues. Okay, so we think this is potentially an area for us to be looking more closely at. So we've done a systematic review in this area, and we found some ways of assessing the mechanics of the tissues that might be useful, so using force transducers and also using ultrasound technology as well. So we've got a basis there, I think, for sort of moving forwards with this area of research. And Najla, after moving back, well, she did a little bit of this as part of her PhD, but when she went back to Kuwait, she's followed this up with some postdoctoral work looking at ultrasound technology, so what we call elastography, which can actually use ultrasound to measure the elasticity of the tissues. So she's done some really good work, showed that the technique itself is reliable, etc., and then showed that it can actually distinguish between people who do have the diagnosis and those who don't. And that's probably best shown by this. It's a little bit redder on my screen, but over on the right-hand side, you've got tissues from hypermobility spectrum disorder, a hypermobility spectrum disorder patient, and on the left-hand side from a healthy patient. Okay, so this is the Achilles tendon. Red are soft tissues. Blue is hard tissues. Green is medium. Okay, and basically what we're able to do is to analyze these images, basically count up the number of red pixels, blue pixels, and green pixels, and as is blatantly obvious from the photograph, okay, we are able to distinguish between hypermobile spectrum disorders and healthy tissues, okay? So we've got a candidate here, I think, that could improve the diagnostic process. If you think about the problems people are having this recognized, having it diagnosed, okay, we've got something here, I think, to work with. There's other technologies that we want to look at as well, okay, but this is showing great promise. And in terms of the effectiveness of interventions, again, we've done some systematic reviews in this area. So this one was from quite a few years ago, 2014, but we did an updated review that was slightly wider, just looking at conservative interventions more widely. So that was just published last year. And again, we'll not dwell on the detail, but just to say that the controlled evidence is really weak, really small studies, mainly only recruit women, only look at one joint, so for example, the knee joint, and no long-term follow-up. Okay, so there's a lot of weaknesses really in the evidence that's out there in terms of conservative interventions. There is evidence that people improve over time. So if you look at the outcome measures, for example, in some of the cohort studies, so single cohort studies, so you can't be conclusive that it's definitely having an effect, but there is evidence that they improve over time with exercise interventions. So they were all exercise interventions rather than other conservative interventions. But there is some evidence that they improve over time, but we don't have that really robust RCT evidence as yet. And we managed to win a bid from the Health Technology Assessment Programme, so part of National Institute of Health Research, to design and implement and evaluate a physiotherapy intervention. So that's the report of that. Again, it was just a feasibility study, so there was only 24 participants, something like that. Okay, so very small. But this is our Bristol Impact of Hypermobility questionnaire. It was a 4-month intervention, so you'll see that both groups, so the green group is the ones that got the physiotherapy intervention, the other group is the advice-only control. So you'll see that both groups improved over that 4-month period, but, and this was designed to be a self-management intervention, you'll see that in the 3-month follow-up, that the physiotherapy intervention continued to improve. Now again, there has to be lots of caveats around this. This is a feasibility study, etc., etc. But the difference between those groups is round about that smallest detectable change, okay? So it's likely to be clinically meaningful as well as the trend being encouraging as well. And we concluded, again, it was a HTA study, so lots of qualitative work in there as well, but this was our final statement in that report, okay, about the fact that we did develop that comprehensive intervention package. It was well received and looked as if it would be promising. And for those of you that are interested, you can go and look at the HTA report for details of the intervention, but all of the patient-facing documentation, the training documentation, all of that's in the report. I suppose the only thing to mention about this is that we used, remember the survey that we did, and we found out what the typical intervention package was. We made sure that we used that resource envelope as the basis for this. So this is something that should be implementable, if that's a word, in the NHS, okay? So we're not doing something really fancy that's, there's no way that it could be implemented, okay? We know that people are using this sort of resource envelope, so potentially it is implementable. And again, just to note some of Sarah's work, so the final part of her PhD basically came up with some patient priorities, particularly around the psychosocial elements again, but patient priorities for what they would like in a self-management intervention. And again, you'll see things in there around education, training, environmental restructuring and enablement. So occupational therapy got a really big thumbs up as part of that. And the model behavior elements, I think, were really interesting. So this idea of vicarious learning and learning from other people's, good practices and mistakes as well. Obviously, again, they really wanted that. They wanted to hear the stories of other people, but within a positive frame. There was a lot of negative stuff about things on social media and stuff like that, but they wanted positive messages, positive information, positive examples. And we're hoping that we can move some of that work forwards as well. Okay, overall conclusions then. Just to say, I think that we are developing a better understanding of the conditions, and we're probably getting to the point where we can say, right, okay, we understand the problem now. We need to concentrate a little bit more on the solutions, okay, so on the management aspects. I think there's stuff around diagnosis that probably we need to do a little bit more on, and tissue mechanics, I think, is looking promising. Obviously, the bio questionnaire we've talked about, we think that is going to be useful for us in terms of our research and clinical agenda as well. We know that therapy is likely to be, so again, the caveats around that in terms of those systematic reviews and our own feasibility study, but we do need better evidence. And the psychosocial factors, again, are sort of currently under-addressed. And if we're to build it all into a model, I think we've got a really complex model here of what's driving pain in these conditions. So yes, tissue mechanics at the top is at the heart of it all, but actually that then is having an impact on the ability of muscles to generate force and transmit force then within the muscle to the tendon, into the joint. Okay, so there's issues there. Fatigue, obviously, is a huge important as well. Proprioception, we know, is massive. So there's actually been a big systematic review and meta-analysis done on proprioception that demonstrates, yes, this is a massive issue. And all of this then is driving problems with posture, problems with movement. And as with any condition, there's that psychological, sort of psychosocial sort of overlay on there as well. So it's a really complex picture, which suggests that any way that we try and help people manage this condition better is going to have to be multi-pronged and sort of quite complex as well. So I think we're well aware of that. In the future, again, I've alluded to the fact that that Najla is doing some work out in Kuwait on elastography. We have a PhD studentship, so we're hoping to interview soon for that, which again will explore these issues around tissue laxity in a little bit more detail. We're doing a massive systematic review at the moment, which is really trying to pull together this idea of impact. So we're only including case-controlled studies, okay, so where people with a diagnosis have been compared against, in most cases, a healthy population, so that we can almost draw a line in the sand and say, okay, we know that X, Y, Z are the problems that these people have. And again, we are using the ICF as a framework for that. So that's ongoing. Hopefully we'll finish and publish that soon. And then on the management side of things, I dearly wish and want to do that definitive RCT. I think that would be fabulous. So we'll continue our search for funders for that. We've got a bid in looking at health professionals. This would be a European-wide survey if we get the funding for this. But looking at knowledge, understanding, attitudes, I think as well, again, going back to this distinction between generalized joint hypermobility and hypermobility spectrum disorders, I think would be really useful for us to understand that better so that we can then address the training and education, if you like, of health professionals. We do need to address those information needs. And Gemma and Sally Pizarro here in Coventry, again, very active in terms of perinatal care for women with hypermobility disorders as well. So, you know, it's been well identified by that group that there are increased complications both for the mother and for the babies as well. So we're hoping to do a little bit more work in that area as well. And going back to this quotation, again, just to say, I think we're understanding the problem a little bit better, so we're understanding the conundrum, and as I've alluded to, I think we just maybe need to move on to now doing it, okay? We need to think a little bit more about the management aspects and how we can actually improve those. Okay, that's me. Thank you.